So I'll start. I'll be brief. But before we get going, it's important to remind ourselves that we are right now, all of us, living in the midst of a global human rights crisis of nothing short of epic proportion. It's difficult to wrap our heads around, certainly my head, around what more than 71 million forcibly displaced human lives means. And what we'll talk about today is that due to the trauma, and the loss, and the stress, and the despair of forced displacement, this human rights crisis has led to an emerging global mental health crisis. And it's in this context that we're here to talk about what might be the role or the roles of mental health research in responding to this social justice and human rights crisis. And really, I feel just blessed to be here with three of the leading scholars and practitioners doing work in the world to better understand and care for the mental health of forcibly displaced people. Ken Miller is here from War Child Holland, and we're lucky to have him. Andy Rasmussen from Fordham University in New York. Brian Hall has come a very long way from Macau. And my name is Amit. I live and work in Haifa, in Israel. And today, each of us will speak for about 10 minutes, and then we'll talk all together and reflect on 4 questions, at least. One is, why might it be that mental health research is imperative to advance social justice and human rights of refugees and other forcibly displaced people? A second question we'll reflect on is, what are the common challenges involved in carrying out this research? We'll talk about barriers to implementation of evidence-based practices in the very, very complex and diverse context in which forcibly displaced people live. And we'll talk a bit about how mental health research can and has adapted to address these barriers. And I hope we'll be able to think together about what needs to happen over the next decade or so in order to promote advances in refugee mental health. And Ken? That's right.
Sure. Super. No PowerPoint for me this morning. I'm still waking up. I just thought is that working? There we go. There were 4 questions, and I could get lost in one of them. So I think what I'll do is get lost in 2 of them. And the 2 that I'm going to just briefly touch on, and I mean more to be provocative, more to throw some things out, and hopefully we'll have some discussion, and rather than offer deep insights, which I lack. So the first question is, what are common challenges involved in carrying out mental health research among refugees in our experience? And I want to start, I tend to be critical a lot of things that happen, my own work, issues in the field, but I want to start by acknowledging some, I think, real progress. Since I first started, I got my degree in 1994, which was a while ago. So since I first started, things have really evolved. The first is, I think, that we have moved substantially beyond what Andy and I wrote about 2010, the narrow focus on war trauma. War trauma is real, of course, and the impact of living through atrocities can be very substantial. But a narrow focus on that, while completely overlooking current stressors, daily stressors that affect people's lives, stressors that are affected, caused, exacerbated by armed conflict. it really hampered the field. It hampered interventions. It hampered our understanding. I think we've moved beyond that. There's generally a consensus now that a more comprehensive view makes sense, both in terms of understanding people's needs and addressing them. So that's a shift. The second is that there's a growing recognition that family violence actually often represents as big a threat, if not a bigger threat, to children and women, in particular, children and women, as actual war exposure. But it's remarkable because since 1975, 1980, when people really began more rigorously studying the impact of war and exile, we asked a ton of questions about the violence outside the home. Boy, we rarely ask questions about what went on in the home. But I'll tell you, from my work in Afghanistan, I think women have more to fear on a day-to-day basis from what goes on inside the walls of the compound, generally, than what goes on outside. Now, that's not to say that the Civil War and the rape that went on in the Civil War and the Taliban's brutality are trivial. They're not trivial. It's simply to say we have begun to broaden our lens. When we look at children, we used to think all of PTSD in war-affected children was from what they lived through in El Salvador or Chile or pick your country. We know now that in the studies that have looked at it, family violence in Afghanistan, family violence in Sri Lanka predicts kids' PTSD as strongly as the violence of war. And the two aren't unrelated, because what we see in every study that's looked at it is a pathway. As parents experience greater levels of distress, chronic adversity, trauma, they are more likely to be thin on coping resources, and children often pay the price for that, which underscores the importance of addressing families and parents and not just children when we want to help children. Still, a lot of the international NGOs that focus on kids focus directly on kids, but there's a shift now to understanding the importance of the broader view here. Finally, I think we're slowly moving beyond what I think has been a very polarizing debate between local versus external approaches to healing. Should we just build on local approaches? Can we bring in outside approaches to healing? And there's been a lot of deep emotion and polarization around that, understandably, because I think at times there's been a real sort of colonialist, universalist kind of approach by Western mental health folks coming in, and you see it in researchers, you see it in practitioners. But where I've landed after my 25 years in the field is that no culture has evolved an adequate response to healing the effects of genocide or mass atrocity. It's not, there are no really adequate responses, and so you pull where you can. I think we've heard in this conference several interventions that are brought in, for example, mindfulness. My own group's work in Amit's group, my group in Lebanon with Syrian refugees, have brought in mindfulness, and it is what people point to as the single most beneficial aspect of this 9-week parent support program. Mindfulness, we don't call it mindfulness, it has links to Buddhism and Hinduism in its origins, but there are ways of bringing together whatever works, adapting it, local, external, and finding how to help people. And to me, that makes much more sense than arguing kind of ideologically about whether evidence-based, kidnet is better than a local way of working with children. But let's try things out. Let's see what we can integrate, what works, and what's helpful. So I feel like we are moving in good directions, and I'm excited about that. That said, I think we're also hampered by a few things. We are hampered by, I can count on one or two fingers, probably one, the number of scalable mental health interventions for refugees and war-affected populations. Actually, I can't even count on one finger, but I think PM+, the World Health Organization's program, has shown enough positive effects in a few settings that it's becoming ready to scale. But almost nothing is scalable. But there's tons of publications out there about effective interventions. Almost nothing can scale. So I think we need to take a critical look at why we're not scaling things. And that is going to require us to also look at what scalable means and whether we're making a little bit of a fetish out of it. Here's what I mean. I just got a grant to do an RCT on this parent support program, Syrian refugees. And boy, the foundation puts hard on scalability. When are we going to go global? As soon as we get our findings. I'll tell you what. If anyone here from that foundation is listening, you've granted us the money, and please don't take it back. If all we accomplish is we develop an effective intervention that reaches several 100,000 Syrian refugee families, I'm going to sleep well for the rest of my life. You know, if we don't scale that so that works with all refugees everywhere, and the question is, what constitutes adequate? What's a big enough impact? Now, I love the idea of an intervention that can be adapted and implemented everywhere, but I don't want us to trip up. Sometimes I think the perfect becomes the enemy of the good. Because as of now, 2019, there's no scalable interventions out there that I can really see. I think we're close to a couple, but we're not there. Let me finish up with just two things, because I don't want to go over here. The first is, you know, we got some of the best methodologists working in this area. Some of them on the stage next to me. I'm certainly not putting myself in that, but you know, I get calls from Andy from New York, and he'd be in the shower. He'd go, "We got to reverse the sign on that one correlation. I just realized before you send the paper out, it's this way. It's not that way." You know, but I am surprised by the methodological flaws that we see in the field. The number of times, for example, people say this is a reliable measure, and they'll cite a reliability statistic from, you know, Iraq, and they're using it in the DRC, as if reliability belongs inside the questionnaire and isn't a reflection of the population that we tested out. I'll see things like, you know, 40% of people had two or three symptoms of PTSD. I don't care. I really don't. That doesn't interest me. Live through rough times, they'll show 2 or 3 symptoms of PTSD. Is it affecting their lives? Do they have the disorder? Are they just having some nightmares? And it's transitory. You know, and this is like a Center for Disease Control level research. We're doing, you know, we are not looking at how to adapt our measures adequately. There was a paper that came out, Michael Holyfield wrote a brilliant paper 15 years ago, where he documented the utter lack of adequate adaptation and development of measures. I fear we are still not doing that. We are just assuming that because a measure worked in place A, it's fine to use it in place B, and we're not examining how do people make sense of these items? We're not doing nearly enough cognitive interviewing. You know, I was on the phone with a big international NGO the other day, and they had run an RCT, but they hadn't piloted all their measures carefully, and they said that none of them worked, and so they couldn't publish their study. And I said, yeah, you know, I did that once earlier, and we also had that problem, and so I've run to really rigorously do all these steps, cognitive interviewing, blah, blah, blah. And they said, we just don't have the luxury to do that. And my feeling is if you don't have the luxury to adapt your measures appropriately, don't do the study. It's not a luxury. It's how you do rigorous research that allows you to say things that are true. And the field of psychology is in a crisis of trustworthiness right now. So I think it behooves us to do that. All right, so I guess the last thing I'll wind up with is this. Last 2 quick things. We still love change the person interventions. We are passionate about changing things inside of people. A recent review just came out this year, 2019, big, lots of names on it, big, high impact, might have been Jan or Lance, I can't remember, looking at the effectiveness of psychosocial interventions for war-affected populations. And what they studied were psychiatric disorders and change the person psychological treatments. They abducted the word psychosocial. That's not psychosocial, that's psychological, that's psychiatric. And I said that to one of my colleagues who's, you know, who knows the group, and he said, yeah, well, psychosocial, you know, it's political, blah, blah, blah. No. When a woman is being beaten at home and we do PTSD treatment with her without trying to alter the conditions giving rise to her trauma, that's not a psychosocial intervention. That's a change the person intervention, and we're changing the wrong person. We're trying to change the woman. So I think we need to think about systems and communities and how we change something beyond what the person is experiencing internally. So my very last comment is this: what is the biggest issue facing the field? The biggest issue is none of the stuff I was talking about. The biggest issue, I think, is this: we are very good at documenting evidence of effectiveness. Sometimes we deal with pilot studies. That's a no-no. That's not what a pilot study for. A pilot study is a feasibility study. Your sample's too small. You should not be studying between group effects in a pilot study. It's just, that's not what they're for. They're feasibility studies. And that's a source of confusion. And people do that, and then they produce unreliable results. Either they don't find an effect that's there, or they do find an effect that's not there. And this is one of the reasons psychology is running into replicability crisis. We do lots of small sample studies, but the real issue to me is when we do it right, and there's a lot of groups doing it right, you know, Paul Bolton's group, other groups that are doing really good intervention studies, rigorous effectiveness studies. When you actually get into the field, and I've been in a humanitarian organization for 5 years now, and you see what happens when people try and implement those same evidence-based interventions, the difference takes your breath away. The difference really takes your breath away. That 7-day training becomes a 3-day training or a 2-day training. The weekly supervision that supported the growth of facilitator skills becomes every 3 weeks we stop by, or when I first got to workshop, every 8 weeks we stop by and we check on them. The really following the manual, the well-adapted, culturally appropriate manual for the intervention becomes, well, we check it, you know, and for the first half hour we use that, but then the next hour and a half of the session we sort of do what feels right. And I think there is just this chasm between researchers and practitioners. And we have gotten off the hook for, in some way, being accountable about ensuring that what happens post-RCT, post-publication, actually bears some resemblance to what we did during the study. And that, to me, it's implementation science, I suppose, is ultimately the biggest issue of all. Because we can keep producing these really sweet efficacy studies, effectiveness studies, and what's actually going on in the field doesn't resemble what we studied. So, leave it at that.
Well, first, thanks for putting this together. It's fun to be up here with some great voices. In a conference which has had some wonderful voices. I mean, it's part of me coming from Teresa Bettencourt's talk was I wanted to come up and say, just, you know, what she said, right? Because she touched on a lot of things which I thought, including implementations. But it's also a real honor to be up here with my good friend and colleague, and really somebody I think of you as one of maybe 2, maybe 1.5 people who have, and you're the 1.5, who have really made me career-wise into who I am today. So thankful. And also thank you for those little anecdotes. The shower. Here's a few of those, so I have to be really nice. Okay, I admire the intervention research that is being done, and I don't have a lot to say about it because I haven't done it. My work has been more around trying to figure out, not in I wouldn't say in a basic science way because I'm a very applied researcher, but in maybe a sort of foundational way, that's not too pretentious a term, defining what it is about forced migrants that make them that make them who they are. And after doing this for a decade and a half, maybe, I've come to a couple of observations that I'm trying to do with my graduate student colleagues in New York in our group on culture, migration, and community. But I also have been trying to do in one form or another for at least the past decade. Started out in this field, as many of us do, coming to displaced and forced migrants from a trauma perspective. Oh, this is a traumatized group, so we need to ask about trauma. And yet, from the first time that I saw someone come in for therapy and had my own clients at Bellevue Hospital, it was clear that there was so much more going on. And yet I wasn't finding in the research that there was a lot of discussion of what's going on. Some of the stuff that can help me think about in terms of the mediating effect of daily stressors or current stressors, ongoing stressors, whatever we're calling them, and was along those lines. And then the other thing that struck me was that a lot of what was being said were phenomena that are common to all immigrants. And I'm still surprised that as a field, there's the refugee literature and there's the immigrant literature, and ne'er the twain have met yet, anyway. And so what we've been trying to do at Cultural Migration Community has been to look at some of those issues that are common to immigrant experiences that are also, that one sees in refugee and displaced persons. Now, of course, that doesn't say that trauma doesn't exist as an important part of the refugee experience, but it does say that there are lots of other things that happen. Of course, trauma exists in immigrant, non-refugee communities as well, right? And migration stressors, the various stressors of migration, be they things that happen along the migration route, which can be more impactful than pre-migration stressors, or be they changes in social status across migration. I had a nice master's by Segal. I see Segal's not in the audience, okay? But that just came out in the American Journal of Orthopsych, looking at the impact of the change in social status across migration. We know that people lose social status. A very common aspect among immigrants, but certainly among refugees, is a loss of social status across migration. And there are some people who gain social status across migration. And both of those things have interesting, at least associations, with changes in distress, if not changes in psychological, the probability of psychological disorders. So I'm struck by the diversity of experiences within categories of displaced populations and how those are similar to, in many ways, the diversity of experiences within non-forcibly displaced populations, what we usually refer to as voluntary immigrants. And I'm a little bit surprised that we haven't done more comparative work. The next piece picks that up, but shows that there's probably some aspects of doing that comparative work that are not so simple. So for the past 5, 6, 7 years, I've been working pretty closely with a community-based organization located in the Bronx, but serving West African Fulani immigrants throughout the New York area. And one of the reasons I'm working with them, well, there's a number of reasons I'm working with them, mostly because I like doing community-based organization work and I like the people in this group. But another sort of academic reason is that this particular population has a proportion who come for forced migrant reasons, based mostly seeking asylum, and then a larger proportion that is voluntary. And so you can do some comparatives. Okay, what if we are holding culture constant, if you will, given that there are usually, when we compare refugee groups and non-refugee groups, we are looking cross-culturally, which adds a whole bunch of complications. If there's a group that we can hold culture constant and look at people who come for forced migrant reasons and compare to the people who come for non-forced migrant reasons, maybe we can further tease apart the phenomenology of being a forced migrant. And I can tell you, doing community-based work with this group, that the agenda that they set has nothing to do with trauma. It has very little to do with even the status of the immigration status, other than we want people to have more stable status, whether they are asylum seekers or they have a green card, which is permanent resident status here in this country, or they're undocumented, right? It's really about the stability of status, your legal status. And psychological factors don't, other than if you have more stable status, you're a little bit calmer, you have less distress or less concern than if you have, than if you don't. Other than that, the sort of trying to figure out the phenomenology of those who come for forced migrant reasons has been difficult because I don't see that many differences. So it really is about the stability of status, at least once people are in a host country, or every settlement country. One of the complications is that when I've worked with refugee groups, sort of communities which come as a refugee group or in refugee camps, is that the narrative of being a refugee is so strong within these communities, and that it's hard to tease out narratives that go counter to the community narrative as a whole. Let me give you an example. So in the stuff that we did, it was 10 years ago now, that you were on some of that stuff with Darfur refugees in Chad. Everybody there is talking about displacement. We had access to UN records, so we could do an actual simple random sample to look at people, not just a household random sample, but a simple random sample. We could go follow up with people. And we found still that about 25% of the people, and these are Darfur refugees, right? If you read the news, everybody's had exposure to trauma, everybody's traumatized. But we found about a quarter of the population had reported no personal exposure to trauma. But there's this narrative of exposure to trauma that was about being a refugee. Being a refugee is traumatized, so yeah, we're all traumatized. With the group I'm working with in New York, even the people who come for forced migrant reasons, when they talk about themselves, they don't talk about being a refugee or seeking asylum. At best, seeking asylum is kind of oh, that's how I got here. And that's how I gained some sort of foothold in this country. Most of those people then will say, yeah, I was at a shop and the police beat me up, or I was jailed for a little bit. And some people will say, actually, those things never really happened to me, but I got asylum status here. And it's fine because my cousin had some things happen to him, so I'm sort of taking his place, And so then this sort of, these categories that we work with in our little subfield here of refugee and forced displacement, the categories mean less in a community where the narrative of displacement is less salient. Whereas they mean almost everything in a community defined by its refugee status. So I guess what I'm saying is there is this incredible diversity within our populations of interest that I don't think we've really defined well. I think it has implications for treatment and for addressing psychosocial stressors, because of course it means that there's really a slice of people and families that who are in need of that sort of treatment, whereas and we don't have a good way of distinguishing who that slice is yet, which I'm a little surprised about after the amount of research that's happened. This brings me to something that we also haven't addressed, and I haven't addressed it either, which has to do with the demand characteristics of our research, which is when you go into, well, say it this way, when I go into a refugee community, people see something and it gets in the way of my research, right? They see a white guy, sometimes I'm wearing a suit, right? So I've got little money, and I am seen as one of the presenters yesterday in the panel where Zachary Steele was the moderator said yesterday, the northern researcher as a here it is. Researchers are conduits of resources from the global north. And in some ways, I see myself as that, and I say, okay, great, I can bring some resources to the community. Maybe it's about passing on resources to the community and doing some redistribution. But in other ways, it's clear that that's how I'm being seen. And so there are really strong demand characteristics of that situation that people will tell me what they think I want to hear. I'll end with an anecdote on that a friend told me who worked in Northern Uganda. And she was using, she had a research coordinator who she really liked, and he had actually been studying, I think he had actually gotten a scholarship to go study in Nairobi during a lot of the conflict. So he wasn't really exposed to the conflict, but he had an appointment to go speak with somebody at the local UNHCR radio show. And she said, oh, I'm really excited to listen to the radio show. She said, you should listen to the radio show. And she had talked to him about his story and knew that he wasn't around in the conflict. But during the radio show, he said, yes, when it happened, I was exposed to this, I was exposed to that. And she came back and said, what's going on here? You know, you said that, you told me you weren't exposed, and then you're saying this radio show. Oh, but that's the story of my community. That's what our story is. We have to do that. It's part of the way that we get resources, but it's also more than that. It's the story of my people here. And I don't think we have gotten anywhere closer to getting at the specifics and first of all defining that those narratives are maybe not they aren't always individual narratives, they're community level narratives, which I think is important to identify. I have community level narratives on their own, but also how that fits into our approach to individuals and families who we treat. Thank you.
Good morning, everybody. It's really nice to see so many people still here on Saturday and focus on these themes. And Amit, thanks for organizing this, and it's really an honor to be a part of this panel with people whose work I greatly admire. I've moved my life 6.5 years ago to China, and during that past 6.5 years, I've been focused on migration and health. So I consider myself really a person who's focused broadly on community issues and migrant community issues, more than specifically one population. Refugees in particular. So, you know, following on Andy's point, I have some slide about that. I think we need to focus on migration from a continuum, looking at it from multiple different perspectives across different periods of vulnerability, including the pre-departure phase. We know that leads to a lot of the disruption that promotes migration in the first place, regardless of the type of migrant population that we're working with. The transit period of time, which also leads to increased levels of vulnerability. And then in the destination phase is an area that has to be really, I think, focused on quite a bit. There's been a lot of research now that is coming out that is focusing primarily on the destination phase as a key context in which exposures to traumatic events or other potentially harmful stressors are quite important. And when we think about communities, we have to think about a broader and holistic perspective. This is also a multidisciplinary perspective, thinking about it from a public health lens, looking at it from a social determinants perspective. We have individuals who are nested in multiple levels of a social ecology that is both potentially resilient and resilience promoting, but also a context that would perpetuate cycles of violence and vulnerability. Andy mentioned visa status or difficulties in the context. Sure, I mean, a lot of populations, whether they're refugees or they're quote economic migrants or distressed migrants, they don't have status, and they won't gain status in the context in which they're migrating to. And so that status difference actually can be quite consequential to people's health and well-being as they try to imagine their futures and consider, basic elements of hope and other factors in terms of their social relationships. We know that the social relationships are actually quite important. And so I was part of a study that looked at in Australia, the Building to the Life Australia study with over 2,000 humanitarian migrants, looking at different social stressors in particular. So post-migration stressors, including poor social integration, economic problems, worries about friends and families. These are quite prevalent conditions, issues that people are facing in the community. What we found is that those issues actually modify the effect of previous trauma. That's sort of what's already been talked about. But as individuals experience more traumatic, stressful events, as their level of social integration stress will increase, the proportion of that population with PTSD also increased. It's not a similar association with loneliness. So, sometimes we forget that individuals have migrated, but maybe they haven't migrated with their family members. So they're in a new context and they're trying to make their way, but they're constantly being worried and preoccupied with things that are happening to family back home. Also not feeling accepted, not feeling integrated, not feeling like there's a pathway that they can actually build that life. In terms of the state of the science of global mental health, we talked, Mr. Betancourt's presentation today was excellent, talking about implementation science. Where we're at now, largely, is a lot of demonstration projects showing that we can tap shift, so that we can train lay health workers to deliver evidence-based treatments, but then the scalability of those treatments are still quite uncertain. And I think Amit told in a review in 2011 Lancet, looking at where are we spending our time and energy, where are we concentrating our research in terms of intervention, and largely they're focused on specialist level care, specialist services, and focused non-specialist supports, largely ignoring more foundational areas within people's lives, like communities and social relationships. So by not focusing on those things, we're really treating disorders and not trying to build and rebuild communities. There's one example of this project, which I'm not involved with, but I just admire kind of from afar. It's more of a social work-oriented intervention, bringing people together to discuss key themes around safety, trust, care, respect, life orientations, and honoring memories of different traumatic events. We're really trying to focus on the community level and rebuilding networks, social networks, rebuilding community ties, the fabrics of people's lives that are so important. So I'm really looking forward to the results of this particular study, because they're looking at this from a rigorous plus randomized control trial design. And up until this point, sociotherapy has largely been small scale studies, uncontrolled pilots, or more anecdotal evidence. But there's enough evidence to move forward with that. So I'm very excited to see what happens. I think we also should be thinking about taking a capabilities perspective. So taking an approach for communities, thinking firstly that they have agency, that they're resilient. We should think about programs that address key health challenges, including mental health, that are co-developed in partnership with communities. I think this photograph really well illustrates community agency, as we see a migrant worker who's organizing women in her own community to talk about key consequential issues that they'd like to address. I also think digital mental health, we haven't talked about technology. The technology as a theme, I think, is really important, especially when we're trying to target scalability and think about scalability of interventions. So many populations around the world have access to smartphones or tablet devices or other technology to facilitate intervention scalability. And when we develop interventions using technology, we can really overcome challenges about language or stigma as well. We've engaged in a process of cultural adaptation and really engage stakeholders in this entire process. So we want to make sure that, for any intervention that's been adapted, make sure it's relevant, acceptable, and comprehensible to the population. But going through this kind of engagement process, we first started with experts in the field from the communities in which we're working, and we talked to individuals in focus groups and did extensive cognitive interviewing and iterated on the content of our interventions, so the images, the text, and the themes, and imbued culture throughout the entire process. There is a similar project going on in Lebanon for refugees from Syria. This is a WHO intervention step by step. So we talked, as mentioned, PM Plus. PM Plus is a face-to-face intervention, but this is actually a digital innovation of a similar intervention. We did the same process with cultural adaptation in China for migrant workers. So I think the other kind of interesting idea is that once we have an evidence-based digital mental health intervention, we work out some of the cultural concerns. We could then go through multiple types of adaptation in different communities. I think we don't talk about this as much, but I think as researchers and practitioners, we have to show up. And so showing up means like joining festivals. It means being present. It means creating community spaces that you can share and talk about, culture, but also talk about issues that are consequential to people's lives. The 1 Billion Rising movement that's taken place now for, I don't know, not 10 years, but several years, recognizing that 1 in 3 women are beaten or raped, so it's 1 billion women. And so this is a community-based kind of dance and organized by members of the community. And so showing up means actually, being an advocate, being an activist, embedding yourself within communities and showing that you care. And I think when we talk about social determinants, we talk about the social context, it also means getting out of the ivory tower into community spaces, helping to co-create community spaces. So this is like the Dragon Boat Festival in China. It's really kind of like it's an annual festival, and making these zhongzi, which is basically like a rice dumpling, is something that people do every year. And so engaging communities in creating those, fully participating in the cultural events and society, I think is a really important thing, and something we fostered a lot and worked on a lot with our own research group. I think we also need to make sure we're doing minimal harm to participants. The ethics of the work that we're doing should be front and center. We did a project with refugees in Ethiopia, smaller refugees in Ethiopia, in a common elements treatment approach. Intervention study was published last year. As a part of that, we also did a mixed methods assessment of reactions to participation in the research process. So this is actually under review, so I'm not going to share too much about what we had found. But 31% of children and 45% of caregivers assessed 2 to 3 weeks after the interview reported feeling upset about doing the interview, and that for more than 4 days, which moderately affected their activities. So there was impairment associated with their participation in the study that we were doing to reduce their distress. That's something we should really be thinking about. And it's an uncomfortable lens to put on our work, because then we have to do something about it. But I think we should. So items in particular that were distressing for the population was Muslim. Questions around alcohol use, about sexual activity, about female genital mutilation. These are questions that they didn't want to answer. Even in the formative, they talked about not wanting to answer those questions. That alcohol wasn't a topic that they wanted to address. But because of the way research is done, we needed to include all of those items to make sure that the scales were reliable. We could use the Oppenbach, et cetera. I mean, these are really like. I mean, that's the status of the work that we're doing, so we have to follow that, right? But I just want to mention, also not to be alarmist, they also greatly benefited from the opportunity to learn more about their children's conditions. They talked about being very well respected during the interview process. They talked about that being yeah, that there was a lot of benefit as well. So it's not just harm, there are harms and benefits, but I think we should be more focused on it. And I'm really glad that Andy mentioned this idea of like a dichotomy that we have in the field. Like there's a refugee and migration tracker at the conference, but I don't think there's any migrant talks. They're all talks about refugees, which is great and really important.
I agree with that.
Yes, it's great. Yeah, but the point I'm making is that distress migration is also really important, and we should be focused on migrants who are not refugees, who are largely hidden and not represented. And when we look at the larger context of migration in the world, refugees are a minority of the larger context of migration. One population that I've worked with quite a lot are migrant domestic workers, which numbers 11.5 million in the world and are largely neglected and invisible, and are trauma exposed. We want to take a trauma lens. Many of them have experienced trauma in the context in which they're working, so abuse by employers and other issues, but also natural disasters and concerns family back home. And in the population we have in Macau, China, 26.5% were screened positive for PTSD. So thanks.
So something we haven't talked about too explicitly is one of the intentions behind being here and putting together a panel like this, which is to encourage and maybe even inspire more practitioners and scholars to do this type of work, despite the complexities, many complexities involved in that. And so in that spirit, I want to share the story of my group's development over the past 8-10 years of trying to develop a refugee mental health research program, and how that led us to try to develop and begin to test a mindfulness-based trauma recovery program for asylum seekers and refugees. So beginning around 2006, forcibly displaced children and adults from Eritrea and Sudan fleeing persecution and other unspeakable horrors began to seek refuge in Israel, where I live. And I'd like to share a short clip from a documentary by the brilliant Karen Shiloh about the experience of asylum seekers, Eritrean asylum seekers. And I just brace yourselves, it is hard to watch and to hear, but I think it's extremely important to do our best to understand the lived experience of being forcibly displaced.
Dear listeners, this is Veronica Stefanos, broadcasting from Stockholm, Sweden, Voices of Eritrean Refugees. The quality is like, I want to end this. He hit a dog in Sweden. He got to jail for 6 months. Here I listen to people being tortured every hour. And the whole world is watching, doing nothing, just.
Max. This is the Bernstein.
taariikh caalamka laga zayfka ana laga qasasa eertrawi bukhta ul kharat harat كنتي اللي بعدنا كنتي اللي كنا تاتنا نعم يقوم تكمل نعم
بشار زودي أمراري بشار زي قلت لكم بيان شغلة عندنا شيء ما شاء الله
And so my students asked me, why aren't we doing anything? And I didn't have a very good answer. So to make a very long and non-linear story very short, about 8 years ago, my students and I moved part of our lab from a really quite lovely campus in Haifa, atop the Carmel Mountains overlooking the Mediterranean. Not the best university, but probably the best view in the world. And we built a shoestring mobile lab in the urban heart of the African refugee community in South Tel Aviv. And in close partnership with members of the refugee community, both Sudanese and Eritrean, and really quite amazing NGOs that serve them, we conducted a number of studies among hundreds of African refugees in Israel. In the central bus station in South Tel Aviv, in a tent outside of a detention center in Khulot in the desert, among torture survivors with Physicians for Human Rights, Rala, and most recently with a really amazing NGO taking care of women and empowering them to take care of each other, Uchinate. So what did we learn? This is really a very, very short bit of what we learned. And we found overwhelming evidence of a mental health crisis among African asylum seekers in our community. And it has many faces, that crisis has many faces. I'll only talk about a few. First, we found that African refugees in Israel had suffered from shockingly high rates of traumatic stress experiences. Prior to, over the course of persecution, some as child soldiers, over the course of transit in Sinai, and on average, some appalling, more than 7 different types of these various kinds of experiences, many of them experienced many times over. Torture, imprisonment, being close to death, and so on. Second, following the trauma of their forced migration, they struggle every day to cope with a wide range of chronic stressors related to simply the objective reality of the instability of their lives. And these include things that folks here have brought the world's attention to in many ways. It's the conflict with immigration officials, fears of being deported, loss, loneliness is a big one, and so on. And this is really, I think, quite reductionist, but it is important also. And I think despite the resilience and their amazing sort of will to survive and even thrive, they also suffer from extremely high rates of what are really invisible scars. I'm not a bad clinician. I look at this community, they're doing so well despite the odds, and nevertheless, they are suffering at extraordinarily high rates from problems like post-traumatic stress, doesn't matter how you operationalize it, depression, anxiety. It's a real, actual mental health crisis, and without any hyperbole. But we also found that some refugees, or frankly, asylum seekers, had largely recovered. And we worked intensively for a few years to try to understand who they were and what malleable factors that we know how to move with existing knowledge may be associated with that resilience. And we came to a conclusion that I still feel still surprised by. And I was surprised after the first sample, and the second, and the third, and the fourth. Which is, to our surprise, that there's quite a robust effect of protective effect of present moment attention to present moment experience with qualities of acceptance and compassion. And were associated with recovery, despite the fact that they have very similar, identical traumatic experiences in post-migration stress. And so, at some point after a few years, we said, okay, maybe we can no longer just measure and study. Maybe, what can we do? And we tried to set out through a long, very similar iterative process to develop something that we call today mindfulness-based trauma recovery for refugees. It's a mindfulness and compassion-based intervention that's trauma-sensitive and also socio-culturally adapted for diverse, forcibly displaced people. And we hope that the intervention would do two things. One, really, and the second was more of a pipe dream. The first was we wanted to help these asylum seekers experience moments, just moments, of refuge and safety in their own body and in their own mind. And we hoped that were we able to do that, we might be able to begin to help those who have not yet begun to recover begin to recover and heal. An intervention involves 9 2.5-hour group sessions and home practice with a kind of cool YouTube channel that students and staff set up into Greenia. The intervention involves psychoeducation on the effects of trauma and stress, and basically mindfulness meditation that's based on MBSR and MBCT with quite a few revisions, and also loving kindness practices to cultivate compassion for their own experience and for that of others in the context in which they live. And a whole host of trauma-sensitive adaptations to mindfulness to make sure that it is safe, to reduce likelihood of dissociation, panic, and so on, led by work by David Truly, very much. If you saw the work presented by Ken's amazing group yesterday, very much in line and identical to that approach. And we then deliver these practices in a variety of ways that are socio-culturally adapted, for a whole host of ways. For example, in all groups we have cultural mediators and translators from the community, among a number of other adaptations. And finally, the intervention is delivered within and by the community, very critical. And there's a whole host of ways of doing that. So it's delivered in a safe space inside. This particular study was delivered inside Kuchinake. Our teams are always 50%, how do you say it in English? Bleeding heart liberal Israelis and 50% refugees. And childcare is provided by members of the group, of the community. Food is prepared by members of the community during sessions. And then we set out to deliver this intervention and test it in the same serious manner that we do clinical science anywhere else in the world. Same rigor of testing feasibility, efficacy, safety, and mechanisms of action. And in this particular study, we recruited 158 Eritrean asylum seekers, women and men. It's not, we couldn't manage, but it's a waitlist controlled study. And we conducted a whole, I'm not going to get into it here, but a whole range of assessments across levels of analysis at 21 time points. It's a lot of data. And we asked ourselves the same sort of questions that you might be asking. Does it make sense to teach asylum seekers in objectively unimaginable context to sit and meditate? It's kind of nuts. And does it work? And again, there's a lot of data, so just give you a snippet. Just going to give you an example. Here you see data over the course of the 9 sessions of this mindfulness and compassion training. And the black bars show levels of, for example, happiness and joy, also calmness and tranquility, look very similar to this, and in the daily lives of these refugees, these asylum seekers. And the white bars show the upticks in happiness and joy and in calmness and tranquility and related processes each week. And we also see this kind of steady growth of these feelings of safety and refuge in their own bodies and experience over the course of the intervention, despite the fact that nothing much in their objective reality has changed. In fact, over this period, it got worse in general. One important question is, did mindfulness and compassion training help refugees begin to heal and recover beyond these moments? And I don't want to take away the importance of the moments, actually. I'm quite happy with them. Ken's happy with several 100,000. I'm happy with 100, actually. If everybody here worked with 100 people, it's a lot of people. It's a lot of deep impacts on a lot of communities that change families. And what we found is, I have to say, I still am very skeptical about this, because it's far beyond what we imagined, and we'll see if it replicates, of course. But almost all of the Eritrean asylum seekers in the waitlist control condition still had post-traumatic stress. Again, it doesn't matter how you operationalize it, with idioms, without idioms, so on. Less than half of the participants who received mindfulness and compassion training still met diagnostic criteria. Many of them were still quite stressed. But there was real movement in their experience. And likewise, for most of them, months later, for most of them, there's no booster session in this particular intervention. Those effects are maintained. And we also found that, like in other actual NDCT and related mindfulness-based interventions, those who are most vulnerable, the most severe trauma history, the greatest levels of post-migration difficulties, actually benefited the most. Precisely those asylum seekers who I stayed up every night, late at night, worried about that are we going to cause them to dissociate and panic? Actually, they seem to benefit by far the most. Really, these are large effect sizes, like a whole standard deviation effect size. They have similar effects for depression and anxiety, although those effects are robust, but they're smaller in size. And is mindfulness and compassion training, was it safe? So for example, is it safe? One of the things that we asked a priori was, maybe it would cause harm to those struggling most to begin with. And we found, and we monitored this weekly with experience sampling data, pre-post assessments, that there was only a single participant who demonstrated some possible, using this kind of reliable change indices, old school RCI approach to identifying robust clinical deterioration. We don't know if it's a function of intervention, but it really seems safe. Much safer than I thought it would be for an extremely vulnerable group. Over the course of the next few years, we hope to carry out a multinational study of MBTR. And we're hoping to partner with NGOs, communities and service providers in urban, it seems to be sort of urban resettlement settings in Europe. And just to ask for help. If anyone has any ideas, suggestions about how to go about doing that, I have no idea how to go about doing that. We have a lot to learn, and we're very happy for advice in this way. And before I let you go, I'll just give you a little bit of inspiration and hope. Sure.
We refugees here were facing a lot of problems, especially with the deportation. It is the mind that gets me crazy, that gets me to be depressed, because all the time thinking things, I'm addicted to it. I don't know how to stop it. When I stop it, I got peace. When I not know to stop it, I get crazy or I'm depressed. It's some like after you meditate, you become like new person. And then after so many hours, you get back where you have been. It's obvious, but for minutes, you become someone very new. I hope so it will be distributed to all of the people and to become part of the refugee system. And it's like a medicine for me, maybe a luxury for you, it's like a medicine for me. It's a different way of interpretation for it. I use it for like a medicine.
Thanks very much. So we have, this time we have about 10 more minutes to talk. We can do it in a lot of ways. One option is, I think it's been decided how we're going to do it. Dr. Steele.
Yeah, thank you. Thanks for the far-ranging discussion that just covered so many issues. Brian, your presentation just really reminded me that you can never predict what's iatrogenic. You know, we always think it's the trauma stuff. You know, and so many communities say, it's not that, but how dare you ask about this? You know, in Timor-Leste, it was about household income. We had, you know, people from Delhi going to rural areas. Now the Delhi people were rich and the village areas were poor. And to have a young person come and ask them about income was just the highest level of culture. And so we had to throw out everything about income. That's what makes them deeply traumatic for that community. I suppose just to step back, one of the great dilemmas we've got in the field is, you know, we've got individually effective treatments and yet we've got socially generated distress. And, you know, how do we mix those things up? Some of you might know Kaz de Jong, who did a whole lot of work with MSF doing some of the early, you know, trauma-focused psychiatric epidemiology. And one of the studies he did was, of course, in Sierra Leone, where he found a 99% PTSD prevalence rate. And he was sort of quite shy about that, you know, and received quite a bit of stick about it. But of course, you know, that was at the time when people were the insurgency was coming into Freetown, and they weren't that far away. And, you know, in discussions with him, we just think he measured terror, you know, which looks identical to PTSD. And in asylum context, you give people a positive outcome and you get an effect size better than we can do with CBT. And it's sustainable over time. So, you know, how do we get this balance right between the psychological and the social? And we don't have a science for the social. I really like, Brian, you talking about, reminding us about sociotherapy, you know, and intervening at that level. So maybe just a comment to reflect on how do we move between these domains in our approach to the field.
Well, it's a fair point. I would love to just have that question sort of be part of a research agenda. Because it merits a lot of debate, discussion, reflection. And I think we have to uncritically sort of just continue doing what we've been doing without pausing to reflect on the research agenda. And I think that's an essential question. I see us leaning very heavily towards responding, as you say, individualized treatments, what are often socially created and socially maintained and socially experienced patterns of distress. So I don't know how we get a reflection on the research agenda and a critical examination of it, but I think that's essential. There was just a paper that came out recently, a few months ago, where practitioners were asked what researchers should be studying, what their priorities were. And what was really interesting is that what practitioners wanted was markedly different than what researchers are currently doing and what we've been doing for quite a long time. And I think that's interesting. The traditional research response has been to sort of scold practitioners for not reading our research, rather than saying, might we need to, you know, reflect on our own research agenda and make sure that what we're doing is responsive to what people need in the field. So I really appreciate your comment.
I want to be mindful of time, but some of what your question brings up for me is that certainly there is socio intervention, sociotherapies, but a lot of what we're talking about, I mean, if status is producing an effect size, you know, 3 times greater than any we can get with psychological therapy, then we need to stop doing research and go do advocacy. And I think a lot of us
have decided that we do research in order to do advocacy, but I'd go a step further. Let's just stop, don't do research, just go do advocacy. I mean, I don't think that policymakers are convinced by P levels or even the rigor of our qualitative studies. But so we should, just go do advocacy if we're interested in doing that. Now that doesn't mean that I'm giving up being a researcher. I like research, and I think it's important to get those narratives out there as much for education of our field as anything. But those, for political problems, call for political activism.
But I just want to quickly push back in on the next question, because your group study, you guys did a study that I cite all the time when I talk, which is you were able to show that release from detention was the biggest predictor of drop in depression and drop in suicidality. It's the same thing that you're talking about, I think, Zachary, which is this idea that status, the certainty you will not be deported. But we need evidence to show that. We need to be able, as researchers, to say, we can show that this is even more powerful than psychotherapy and psychiatric medication. And I think the issue is not so much stopping being researchers and becoming advocates, is that as researchers, I think by and large, we have failed to also be advocates. And the first question that you pose when you send us questions is, how does research contribute to human rights? And the answer is, by and large, we don't. It could be. But we need to add on the role of advocate, which of course challenges the kind of notion of the neutral objective researcher in the laboratory, which I think we've let go of, but we need to take that role on.
I just want to say one more quick thing. I think it's something that's come up a few times in this meeting, and I think it's very important. I think it's something that a lot of groups do, but don't talk about and don't study systematically. I think, and it's something that my group has talked about a lot and struggled with for many years now doing this work, is each of us needs to do what we actually know how to do well. I don't mean we just stay in our lane, but a bit. And one way of doing that is by partnering. There's all this talk in academia about interdisciplinary this and that. Well, you could also, we've tried to do this, and it's hard. We haven't studied it systematically, but I think a lot of groups we work with. NGOs that do advocacy. We work with legal clinics that provide various kinds of pro bono care for asylum seekers. We work with psychosocial organizations that take care of, and at least to try to address education issues, occupational issues, violence in the home. And so I'm not convinced that we need to let go of private, hidden mental suffering, but there's no doubt that we need to contextualize that, and we need to do our part to partner with those who care for the rest of the ecology of these human lives.
I just want to comment about that too. That's really thought-provoking. I recently I heard the term embedded activism because I really have been struggling with the idea of trying to situate is it advocacy, is it activism, how should we be thinking about our role, are P values relevant to policymakers? These are really important questions, because as I'm really focused on the social determinants of health, then the natural next step would be then policy interventions, social interventions, contextual-based interventions, not digital mental health. And so I don't mean to present like a kind of an incoherent narrative. Like digital mental health is something scalable for a lot of people that do have a common mental disorder. So that's one solution. There might be other solutions. So all the work I've done has included policymakers from the very start. So getting local legislative assembly members in my context who are going to be advocates for the population that I'm working with, and then getting consulate members and staff, getting them informed about what we're doing, trying to generate that kind of like the embeddedness of the activism of like working within the system to try to create system change, and that's a slow process. I'm also in China. I'm also not from China, so it also creates a lot of complexity. And I've been really thoughtful about that, because like this is not my home, and then my stimulus value or demand characteristic is also something I need to be managing, thinking about, and being strategic about with the communities that we're working with and with NGO partners. So I think there's a whole system trying to make change, and that is actually the more difficult thing than running an RCT. That's like that, and I don't know how many decades it would take to actually affect that kind of change, but I think that's the change we should all be trying to work towards.
Thank you so much. This has been so informative and inspiring, actually. Following the Second World War, the psychiatrist and historian Carl Jaspers said that periodically humanity must think itself free. And it seems to me that, you know, if you look across the globe, it's really critical that sort of new paradigms of thought need to begin to animate humanity as a species. That it's not sufficient to tackle these problems one at a time, that we need sort of a new visions for the future of humanity. And I'm just wondering, you know, we talk about interventions as psychologists, and we talk about having population effects. And I'm wondering whether you think institutions like this, or organizations like this, ought to begin to shift the discourse to seeking to influence really the broad thinking of humanity about its future, and not just focused on doing well-designed analyses of the kinds of problems that we are facing in this country and that country.
Wow.
Big question.
Smash the patriarchy.
I think that two things. In addition to the fact that we're out of time, and you guys have been great, he wants us off the stage. The second thing is, I think that is quite something you're asking. I have no idea. I want to say that, yeah, I don't know how we go about doing that, and I agree with you that that is not the way we've been thinking as a field, typically. But I think in many ways I wish it were. Thanks to you all. It was fun.
Yeah, I'm sorry we're out of time. Yeah.
We needed to have managed the time a little